Now let's see one of the anterior incisions we can do in the chest, which is the median sternotomy. So median sternotomy is the most common incision we use for cardiac surgery. This is going to be a vertical line through the sternum, a midline vertical line through the sternum. So first, here we have the patient. The patient is placed in a supine position. We want to bring up the chest, so many times we use a bulk of sheets under the patient chest to bring up the chest and have better exposure during surgery. We also have the arm close to the chest. This is to improve exposure of the chest and also for the arms not to fall. And then our landmark is going to be the suprasternal notch. Here is the suprasternal notch. The Lewis angle, which is a prominent part here of the upper sternum. So here would be Lewis angle, and lateral to this is the second intercostal space. So we palpate suprasternal notch, then we feel we go down, we will feel a prominence, which is Lewis angle, and lateral to that we will find the second intercostal space. So here we palpate suprasternal notch, we draw a line for this suprasternal notch, then we palpate Lewis angle, lateral to that is the second intercostal space, and we palpate the xiphoid process. Here, the xiphoid process. So these are going to be our reference for the median sternotomy. And we are going to mark this on the patient before preparing the chest in a sterile fashion. So suprasternal notch all the way down until a prominence, which will be the Lewis angle. Lateral to that is the second intercostal space, and then we continue down to feel the xiphoid process. Now, to make sure we do a vertical incision for skin, a completely red vertical incision, we use silk suture. So we use silk suture. We place one tip of the suture here in the suprasternal notch, and we grab the other tip here of the suture all the way down to the xiphoid process, and we push down. So we are holding the tip of the suture with the left hand and the other tip with the right hand. The suture is passing through the suprasternal notch and through the xiphoid process, and we push down. So this is to make an impression of the silk suture, which could be our reference as a straight vertical line. So when we do the skin incision, it will be exactly in this impression. So we mark that impression with a marker. Now that we mark the line incision, then we can start preparing the chest in a sterile fashion, so with soap and with alcohol, then the sterile dressing of the patient and the iovan placed on the chest. Now, after the patient is ready for starting surgery, we have the reference line. So we will use a 23 blade for the skin incision. The skin incision is going to start more or less 3 fingers below the suprasternal notch. So our landmark is suprasternal notch, and we go down 3 fingers, below the suprasternal notch, down the suprasternal notch. So 1, 2, 3, and here we will start the incision all the way down to the C4 process, following our previous mark with a 23 blade. This is to cut the skin, and barely we can cut the fat tissue. Then we will use cautery at 50 watts. Cautery at 50 watts to dissect or to spread the fat tissue. Spread fat tissue. Here in the midline, here is the suprasternal notch, and all the way here in the C4 process, which is hard to get access here and here, all the way until we get to the sternum. So we will be dissecting here. With the left hand, we spread the fat. With the right hand, we use the cautery all the way until we see the sternum. When we see the sternum is covered with periosteum. So when we arrive to the periosteum, the sternum periosteum, we are going to do an incision with cautery, or we are going to mark the vertical line for the saw when we saw the sternum. So let's suppose we already arrived to the sternum. We will have the sternum covered with periosteum. So all this is going to be periosteum. And so with cautery, we use it here, which is not exactly to separate the periosteum, is to mark the line for the saw. And we also need to do blunt dissection of the pericardial sternal ligament, which is all the way here. So we do blunt dissection. We have already marked our incision for the saw, and then we use the saw, and we do a vertically line. We can use the saw from top to bottom or from bottom to top. Most of the time is done from top to bottom, because we don't need an assistant to do this, or we can do it without an assistant. So we use the saw from bottom to top, and then we will have spread the sternum. So now the sternum is divided into 2 equal parts, and we are going to have bleeding. So bleeding from the sternum, and also bleeding from the from soft tissue around. So we will have bleeding here, and the soft tissue around. So for soft tissue bleeding, we use cautery, and for the sternal bleeding, we will use wax. So here we use cautery to stop the bleeding of the soft tissue, and we use wax for stop the bleeding of the sternum. Now, behind the sternum is going to be the heart covered with pericardium. So before actually seeing the pericardium, the heart, we are seeing the pericardium. We need to do an incision in the pericardium so we can see the heart. So now that we have divided the sternum into two equal parts, we use a retractor to separate more the one half of the sternum from the other and have better access to the heart. We will see the pericardium, so we can still using the cautery to incise the pericardium. We have first the parietal pericardium, then we have the visceral pericardium until we get access to the heart. So we will be more separated. So after the incision in the pericardium, we will be able to see the heart. So I'm trying to draw the heart between something like here will be the right atrium, the right ventricle. So we will see more details of the anatomy of the heart, but now we will have access to the heart, and we want the pericardium, which is covering the heart. So here is the heart, this is the pericardium. We incise the pericardium, and we want to lift the pericardium permanently with sutures. So we don't need to with one hand pull apart the pericardium and having access to the heart. So here is the heart, the pericardium, we incise the pericardium, and then we use sutures to lift the pericardium. So we will have so we will have the heart, and let's say this is right atrium, right ventricle, left ventricle. We barely can see the left atrium, and here will be the aorta, the pulmonary vein, and all this is covered with pericardium. So pericardium, we do the incision in the pericardium, and then we place a suture passing in the pericardium. So this is the pericardium, we do the incision. So we use a suture to place it here in the pericardium, and then we pass the suture in the soft tissue of the chest. So pass it here is the pericardium, and in the soft tissue of the chest we do a notch and cut. We do several of these, so we have the pericardium close to the chest like this. And now we have full access to the heart without the pericardium being on the way. And then we will be prepared to cannulate the vein and the arteries, which is what we're going to see in the next video. So median sternotomy is the most common incision for cardiac surgery. This is a midline vertical incision in the sternum. Our landmarks is going to be the suprasternal notch, Lewis angle, which lateral to that is the second intercostal space, and the xiphoid process. The patient is placed in a supine position before before the chest we prepare in a sterile fashion. We use silk suture to get an impression as a vertical mark. we draw a vertical impression, then we prepare the chest in a sterile fashion, then we use the 23 blade to cut skin in this already drawn vertical line. We use cautery to the section of the fat. With the left hand we spread the fat, and with the right hand we use cautery all the way until we arrive to the sternum. We will have the periosteum of the sternum. We will mark it, we will brand the periosteum with the cautery to make a line in the sternum, which will be our landmark to use the saw to break the sternum. And we need to do blunt dissection of the pericardial sternal ligaments or pericardial costal ligaments. Then we can use it top to bottom or bottom to top the saw. We will have apart the sternum. We will use a retractor to separate more the sternum. We will see the heart rattling pericardium. We continue dissecting the pericardium, so we will have a hole in the pericardium, and we lift the pericardium with passing sutures in the pericardium and in the soft tissue. So we are lifting the pericardium, and we will have access to the heart, and we will prepare to do cannulation.